This is lesson 7 of module 213, physical disabilities and personal care. And in this module, we'll focus on dementia, or if I'm using the more current terminology, neurocognitive disorder. So I've chosen to stay with the term dementia for a little bit longer, although we're on the borderline, I think, of the new term taking over more. Many people still use this old term, especially people in the medical profession, and so that's why I have chosen to talk about it using that label. But the correct name is, in fact, neurocognitive disorder, and again, that gives us a bit of an idea of what's actually going on. Neuro refers again to the brain and the nerves, and cognitive refers to our thinking. So what it's basically saying is that these are disorders in which our thinking ability is diminished because our neurological activity is affected. Now, there are many causes of dementia in kind of chronic illness such as Huntington's disease, Parkinson's disease, HIV, just to name a few, can cause a person to have dementia. And so can the same sorts of risk factors that cause people to have a heart disease. So a person might have a vascular form of dementia in which the blood flow to their brain is affected by them having something like plaque buildup in their blood vessels. But we're going to focus on Alzheimer's type of dementia because it's the most common and because there is a particular connection between Alzheimer's type dementia and people with intellectual disabilities, specifically people with trisomy or Down syndrome. Down syndrome is one form of trisomy, a genetic condition in which people have an extra chromosome. And what we know is that most people with Alzheimer's disease would get it, or Alzheimer's type dementia would get it at 65 or older, but people with Down syndrome can get it at 45 and older, and sometimes even earlier than that. And so understanding that Alzheimer's is something you may come across in that subset of the population is particularly important. When we think about dementia, most of us already know that the most dominant symptom is a loss of memory. And I mentioned it earlier about another diagnosis that people may sometimes lose one type of memory but not the other. They may lose their long-term memory but not their short-term memory. Well, actually, in this particular case, what's much more common is for people to keep their long-term memories. They last the longest, and to lose their short-term memory. So they may forget who you are or what you're doing in that conversation, but still remember things from their childhood. They may also lose a number of other executive functions, and we're going to look at what that means more in the next slide, so hold on. And there can be a whole host of psychological and behavioral symptoms. In a nutshell, I would describe people as having very significant behavioral change. People that might have seemed passive, calm, and gregarious might become active, aggressive, or wanting to be alone. And sometimes these changes seem to happen all of a sudden. An interesting thing that I've noticed is that you might see a person seem stable for quite a period of time, and then all of a sudden there seems to be this radical change. And this particularly seems to be caused by some type of stress or change in the person's life, although there are lots of times when there's just no simple reason or explanation. Alzheimer's type dementia is a fatal or terminal illness. Other forms of dementia aren't necessarily going to be terminal, but some of them are. And unfortunately, dementia can sometimes take many years, so people might actually have dementia but not pass away from it. Something else might kill them first, heart disease, cancer, to name a few examples. So what do we mean by executive functions? Well, I'm going to spare you the fancy terminology. You've already used some of those in previous slides. But basically, any of the types of things that you might think of as the tools that you use to navigate your day. Things like communicating with people or finding words, speaking, would be affected by Alzheimer's disease. People often can't remember the names of simple things or where they place something and they simply can't find it a few minutes later. Complex tasks or tasks that involve steps are also often affected. Anything that involves planning or organizing, prioritizing, decision making, and so forth. Difficulty with coordination of their body and with motor functions, and that can even include something like swallowing. And people may become disoriented. They may get lost in places that they have no reason to get lost in, that you're typically very familiar with. Or they may not be able to recognize common people or objects in their homes or in their area. And this is how people become lost, even if they're in the same neighborhood where they grew up or where they've lived for many years. The psychological symptoms I spoke of earlier, you'll see personality changes, and quite common people may become angry or aggressive even though they were never really like that before the symptoms started to show. They may not be able to reason as clearly. They may have sort of gaps in their reasoning. They may have impulsive behavior, disruptive behavior. People suddenly want to go out, or people ask for food and then suddenly get up in the middle of the meal, leaving their food on the table. They may experience paranoid thoughts where they believe that you or other people are there to harm them. They may have agitation. Now, agitation doesn't necessarily mean anger, it sort of means unrestrained energy. And that agitation could be emotional, like anger, but it could also be motor agitation, such as limbs that are tremoring or moving without control. And even occasionally, you'll see people having hallucinations. And you'll remember that hallucinations are false sensory experiences. For example, people hear, smell, or see things that aren't evident to anybody else, that aren't real. So what do we do for people with dementia? Well, particularly for people with Alzheimer's, it's important to understand that we do not know of any cure for people with Alzheimer's. And in fact, we can't even definitively diagnose a person with Alzheimer's until after their brain is examined post-mortem. But we're pretty good at recognizing it based on symptoms. The medication that people take when they have Alzheimer's, very important that they take it and take it regularly. But what it's there to do is really to slow the progression of their symptoms. They're not reversible. So the medication helps to make sure that the symptoms go as slowly as possible. And I've known people who have refused the medication associated with Alzheimer's type dementia, and they had a far faster decline than people I've known who didn't refuse. Now, of course, that's anecdotal, but the medications are designed to slow symptoms. There is no particular rehabilitation, and this is one of the things that's quite different about working with people with this who have this disorder, is that we expect decline. So we aren't trying to rehabilitate people. Instead, we're gradually having to readdress their needs and add in layers of care. And so that's a little bit of a different scenario for us, where we very carefully decide when we need to add more intrusive or restrictive care. There is a lot of physical care, and it will tend to get greater, and it will also be important for us to supervise people. So literally, we do typically get to a point where people have to have locks on their homes to keep them from going outside, or locks that keep them from having access to other risks, such as hot water that they could get scalded in, or machinery, for example, that they could get hurt in, even like their car. Palliative care is care we give to people when we know they are close to dying. And what we do in palliative care is try to provide for the spiritual, physical, and emotional comfort of people. So, for example, people might have medicines that help them to feel less pain. They will typically be in a facility or surrounding that allows them to be most comfortable. So people sometimes actually have hospital beds that are moved into their own home, or they may go to a palliative care hospice, which doesn't look like a hospital, even though it might be situated in a hospital. Often it looks much more comfortable, almost like a hotel. Time with family and friends, spiritual care, such as we might have from a pastor or other ministerial figure, chances for people just to have quiet and have their symptoms managed, so that if they are hungry or if they're uncomfortable, somebody is there to address those needs. Recognize that people may have, with this diagnosis or some of the other ones that you'll come across, something called a DNR, or abbreviated DNR. And DNR is a medical term or abbreviation for do not resuscitate. And essentially what it is a person who has ordered, when they were of fit body and mind, that they did not want to have extraordinary measures undertaken if they became unconscious or entered a state where they were at risk of dying. They didn't want somebody to, for example, defibrillate their heart or put them on a ventilator. And the reason why people may choose this is that they may have accepted that they're going to die and not want to extend that for reasons of dignity or pain management. And so it's really important to understand if a person's file or record includes a DNR, because there's a really clear protocol around that. And essentially, when a person has a DNR, we provide for their comfort, we notify their family, and we maintain their privacy, and we allow them to pass away with dignity.